All right. Good morning from Coffs Harbour in New South Wales, and afternoon if you're in the States. And I noticed on the chat there we've got a few people from Jason in New York. Have we got sound now? Sound on, we're saying. Don't want to say we don't have sound. I think we should. I've just unmuted now, so I was just giving everyone time to log on. I think we're close to 80 people live at the moment for our 10 common Tourniquet mistakes from TacMed. Where else? We've got Canberra, Matt's in Canberra, Joss in Virginia, Sacramento for Gabe, Steve's in Brisbane. We've got Sejuna in South Australia, Texas, California, Matt's in Perth. G'day, Matt. I see you had in England there somewhere as well. I think we had a Greece, Netherlands, Germany, Singleton in the Hunter Valley. So hello to everyone and welcome to our first webinar, hopefully first of many webinars that we're going to be doing here at TacMed. So I'll just throw the screen over to Dan and he can say good morning, and then we'll crack into our webinar.
Yeah, morning guys, up in tropical Queensland here. Welcome from all around the world. Great to see you guys all logging in. So look, as Jez just introduced, this is the first, so bear with us with any technical glitches, and looking forward to a good discussion here. We're going to keep it relatively succinct, but just basically touch on the main issues that we've come across in our careers with regards to arterial tourniquet application, some of the errors that we've seen permeating in training around the place, and just actually looking at the chat there, noticing there's still no sound for a lot of people there, but some are getting it, which makes me wonder whether it's at people's individual ends. I'm not sure if Jez, anything we can do there to improve things.
I'm not sure. I'm try clicking on the video screen, Dave's saying. I suppose let's sounds okay for me. Sounds good in Perth, Matt's saying. So it just could be, depends on maybe some people's internet connection there, Dan, and where they are. It also could be even on crappy African internet, Dave's saying. So got sound in California. So I think we're good in most places. So it could be maybe people's internet connections got clear. So I think we get into it. Dan, what do you think?
Yeah, let's kick off so that we can get people have to head off to work. We can get this done and get people out the door.
Or to bed for some people, I suppose.
Yeah.
All right. So we should just changing over now the screen. Hopefully, should have our 10 common tourniquet mistakes on myself, Jeremy Holder, and Dan Pronk. You can see that there, Dan.
Yep, got it.
Beautiful, all good here. All right, so we're going to crack into our presentation now. Hopefully, we're going to aim for around the 45 minutes. Definitely keep you under an hour, but hopefully get some good value out of our presentation here. We've got a couple of polls throughout just to find out some things, what tourniquets you're using and your level of clinical ability and whatnot. And if you've got any questions, please, you've got the chat there. Most of you worked out, so drop us a question. I don't think we'll be able to answer all of them, but we'll try to get to as many as we can, depending on how we're going with time. So we'll start with who we are. Myself, Jeremy Holder. So I'm an I'm the managing director of TacMed Australia. I founded the company in 2010. So I think we're about 2 weeks out from our 7th anniversary of the company. ex-Special Operations Command platoon medic with deployment to Afghanistan. Also, after military life, became an intensive care paramedic in Sydney, Australia, and so we're based in Coffs Harbour in New South Wales, Australia, and we conduct tactical medicine and emergency medical training all around Australia, and recently some international engagements, which is very exciting for us. So that's a little bit about myself. Dan, do you want to tell us a bit about yourself?
Yeah, so Dan Pronk's my name. I work as the medical director for TacMed Australia. In my civilian capacity now, I work as the deputy medical superintendent at a regional hospital in Australia, working primarily out of the emergency department there. My previous role in the Army was as a special operations doctor, so regimental medical officer for Australian special operations units. In that capacity, spent a decent amount of time on deployment, logged a couple of years in Afghanistan on special operations there, and got some good exposure, a couple of other trips here and there. I also, as part of my civilian capacity, am an instructor for the Australian College of Surgeons Early Management of Severe Trauma course.
Awesome. So, Dan and myself, we've both applied tourniquets in anger. I've probably done a couple of dozen in real life, and probably thousands in training, but a couple in real life. So I'm going to try this first poll. So, have you ever applied a tourniquet in anger or on an actual patient? So let's see this. That should hopefully pop up on your right there, the poll. So we got some going through there. That's interesting. So far we were close to 50-50. I'll leave that going just for a little bit more while I go on to the next slide. So currently we're at about 36% have, and 64% said no. So that's great. We're quite a good number of people that have applied a tourniquet in anger. All right, so we're going to crack on with our first presentation. And as I said, if you've got any questions, feel free to pop it in the chat there. So Dan, mistake number one that we see people make is using tourniquets as the last resort, and after all methods have failed. Now, I will say that we don't want to just be placing tourniquets on every single extremity or limb bleed. In most cases, outside of the tactical environment, we still want to assess the bleeding, the wound, and the bleeding, to work out if it requires a tourniquet. Most of us most people in the military setting are aware of the tactical combat casualty care guidelines, and obviously in care under fire and tactical scenarios, a lot of the time we will use a tourniquet as a primary method of hemorrhage control. But some people will, going back to sort of standard hemorrhage control and pre-hospital setting, they'll apply some direct pressure, maybe put on multiple dressings, and then after they've had minutes of uncontrolled hemorrhage, they'll then apply a tourniquet. And the studies have shown that if we place a tourniquet on prior to the onset of shock, we have a really good survivability rate. Studies showed up to sort of 96, versus if we leave a tourniquet on, we place it on as that last resort, patient goes into a hemorrhagic or a hypovolemic shock, then you can have survival rates of 4% when you place the tourniquet on after shock. So we want to get these tourniquets on early, but again, we can't step outside our guidelines depending on where you are. If you work for an EMS service or an ambulance service, then sometimes you have to go through direct pressure and other indirect pressure methods before applying a tourniquet. Dan, we were talking about even as of January last year with the recent Australian Resuscitation Council guidelines that they're still recommending that it's a last resort. What's your thoughts on that?
Yeah, certainly. It's interesting looking at that poll with about 60% of the audience having never applied a tourniquet real time, and that's understandable. I mean, it's not something that's terribly common outside of the combat environment, and it's hard to know what you should put a tourniquet on and what you might be able to control with direct pressure unless you've seen a lot of this sort of stuff. The interesting, looking at Paul's question there, are these mistakes something you see across the globe or just where we're at? Across the globe, Paul. So both Jez and I have had the opportunity to train and operate with operators from all nationalities in multiple countries. And we do see these are the recurring themes that we see to answer that. And Jason, looking at your comment there, that's very similar to what we're seeing in Australia, second line use. So not quite last resort, but if you've failed already with other applications of direct pressure or compression dressings, these kind of things, then move on to your tourniquet use. That's a different stance, as Jez mentioned, to the TCCC guidelines, where it's a first intervention. So, I mean, the important thing to realise here is it's contextual. If you're in a high threat environment where you don't have time or the light or it's not tactically appropriate to really accurately assess the wound and say, yes, that does need a tourniquet, then you want to apply it straight away. And so hence in TCCC, we apply them straight away. In a civilian environment where you might have a bit more of an opportunity to assess a wound, to expose it, you've got better light, you've got stable tactical conditions, then it may be more appropriate to assess it quickly, try something else first. But the point is, move it really quickly onto arterial tourniquet application if you're failing with your other measures. And some guidance that I used to give to the medics who I worked with was, if you're even thinking tourniquet, then use it. If you're looking at something that's just hosing blood, then get straight on and use a tourniquet. The caveat being if it's amenable to, so on a limb low enough down to get a tourniquet above it. Yeah. But if you're thinking it, you should probably use it.
Yeah, definitely. I mean, studies have shown they are very safe for sort of up to that 2 hour period, which I'm sure we're going to talk about a little bit later on. So a big one from this one is, we don't want you waiting till the patient's in shock to apply these tourniquets. We know the outcomes not very good. All right, Dan, I'm going to hand over to you for mistake number 2 that we see.
So for mistake number 2, placing the tourniquet too close to the wound. So there's been some interesting debate over the years relating to where you should put the tourniquet. We've gone from initially putting it nice and close to the wound to going high and tight, so above the joint, and then we've sort of come back to agreeing that you can put an effective tourniquet quite low down. Now, just to talk more to some of that debate, the argument for putting a tourniquet closer to the wound is if you're cutting off the arterial blood supply to anything distal to that tourniquet is not going to be getting blood, it's not going to be getting oxygen, it's not going to be getting rid of its waste products, and you're at risk of damaging that tissue. You're going to damage nerves. Eventually, if you leave it on long enough, you're going to damage the tissue. It'll become non-viable and, in effect, dead tissue. So the argument is that if you've had a lower leg blown off and you put the tourniquet right up in the groin, there's a good amount of viable tissue there that you're cutting the blood supply off to. Now, as you move down the limb, and particularly on both your upper and lower limbs, if you move past the elbow and knee, you've got 2 bone joints in your forearm and your lower leg, and the artery runs in between them, and it becomes a little bit more hard to compress that artery. In the upper limbs, you can squash that artery straight against the one bone in the upper limbs, and you can get good arterial occlusion with your tourniquet relatively easily. It's a little bit harder in the lower limbs, but certainly achievable. So the stance that the TCCC committee now takes is to put your tourniquet more closer to the wound, so not necessarily high and tight in most contexts, but you need to leave a distance between the wound and your tourniquet. And what they recommend is 2 to 3 inches or 5 to 7 centimeters, depending on which system of measure you're using. Now, the argument for that is you want to leave a decent amount of uninjured tissue above the wound for the concern that there might be arterial sever, so damage to the artery, causing the artery to retract. Now, it's not going to ping all the way back up. It's not going to retract sort of right up into your groin from a thigh wound. But
so not like the Black Hawk Down there, Dan, where the medic goes fishing in his femoral artery with the forceps.
Well, look, it can, and that's high femoral injuries. That's something that you couldn't tourniquet. That's where we talk about our hemostatic dressings and junctional tourniquets. But certainly we can see a degree of arterial retraction. Arteries are elastic piece of tissue, and so it will retract. So a good 5 to 7 centimeters or 2 to 3 inches above the wound, and then put it on, assuming that's not at a joint line, is where you don't want to put it. The caveat to that is if you're uncertain as to where the highest point of bleeding is, so if there's multiple injuries, say a blast type injury where the casualty is peppered, or if it's a tactical environment where it's not appropriate or it's low light and you can't get a good assessment of that limb, then put it high and tight, get it right up in the groin, and then as soon as you tactically can get white light onto it or it's appropriate to do so, have a better assessment of the wound and look at potentially revising that. But the teaching is 5 to 7 centimeters, 2 to 3 inches above the wound. If you can see the wound and there's one clear wound, if it's unclear or there's a tactical environment, high and tight, and then revise it when you can. So
I'm going to throw up another poll here, Dan. I'm just going to put this poll live. So where is your go-to placement to everyone watching this? And I'm going to put this in a non-tactical context. So just your standard pre-hospital environment, or even if you're just in a civilian context, driving home from work and a motorcyclist comes off and has an arterial bleed in their lower leg. Are you still going to go high and tight, or are you going to go that 2 to 3 inches, 5 to 7 centimeters above the wound? So currently we've sort of got 35% would go high and tight as their go-to placement. And again, remember I said this is non-tax. So we got about 65% there saying they're going to go just above the wound. So that's great. And just if I can just respond to Dave's question there, talking about references and that 96% survival rate if TQ used pre-shock. To talk to that really quickly, there's been a couple of studies, Dave. The first that I'm aware of was done by Kra et al. In 2009, looking at survival rates pre and post hemorrhagic shock. But we'll send out an email with a bunch of references on it rather than get sort of caught up in that at this point. But cheers for that. Definitely. Good question. Yeah, we talked about that, didn't we, Dan? We don't have time. I mean, everyone knows that most references are a couple of lines long. So everything we sort of talk about, we'll pop out a reference probably in the blog in the next few days there, so you can look into it. Any other questions? Yeah, so from Liz there, just talking about how long you can leave one in place. We're cognizant of time, and we might move on. But Liz, broad brush. I mean, the TCCC committee recommends revise it within 2 hours. There's data to suggest 6 to 8 hours before you'll definitely injure a limb. But certainly 2 to 3 days as a remote medic, way too long. If you've left it in place over 6 hours, it needs to be removed in a surgical facility where you can monitor the casualty for fear of all the waste products that have built up in that limb getting released into the system, particularly potassium, and possibly causing cardiac arrest. So revise it as soon as possible, convert it to a hemostatic. Definitely you will want to try and get it off within 2 hours. And if you're looking at 2 to 3 days, then probably need to have a good hard look at your evac plan there, because you need to be getting patients to definitive care sooner than that. All right, excellent. So there's some great questions coming through, and interesting poll results there as well. I think everyone should be able to see them now as well. So I'm going to talk about, there we go, mistake number 3, making an improvised tourniquet with a belt or a piece of clothing and not using not using a windlass. I mean, you know, I suppose being an equipment company, we always, I suppose we're a little bit biased given our backgrounds and being an equipment company that, you know, tourniquets, commercial tourniquets, and our preferences are certainly the cat tourniquet and the soft T wide tourniquet. So they're our two preferences, and they're quite affordable these days. So they're quite small, they're lightweight. There's not too many. I don't see there's too many excuses to not have them, and certainly a lot of agencies around the world should be carrying a commercial tourniquet. But you know, there is certainly occasions where you have to make an improvised tourniquet, and it's very hard to do off the cuff. There's a great blog post on our website that Dan did a few probably 6 or so months ago now on making an improvised tourniquet out of items in your car. But again, you know, to make an improvised tourniquet, it needs to have a windlass of some form to get an effective compression around the limb and the tissues to occlude that artery. I mean, the studies have shown that the non-windlass improvised tourniquets have failed to stop bleeding in up to 99% of their applications versus improvised tourniquets with a windlass of some form that only failed to stop bleeding 31% of the time. You know, I don't know too many methods of making an improvised tourniquet with a belt and it being effective. Same with clothing. You can make an improvised tourniquet out of clothing or out of a triangle bandage, but again, it's about using a windlass to get that compression. Take anything away from those first responders and bystanders at the Boston Marathon bombing, because that would have no doubt been a horrendous situation and had minimal equipment there. But there's some studies, not studies, but a paper that was done soon after in 2015 that showed there's 27 tourniquets applied, and all of those were improvised. None of those were commercial tourniquets. There was, I believe, a journalist's photograph of a cat tourniquet in situ, but there's no documentation on who applied it or where it come from. I don't think Boston EMS had cat tourniquets at that instant. They were using a rubber tube sort of tourniquet, which is still technically improvised. One of the trauma hospitals that received 6 of those tourniquet patients documented that none of those had a windlass, and none of those tourniquets were effective. All 6 of the improvised were ineffective, and there was talk that, you know, in some of the other hospitals surrounding, they also had ineffective improvised tourniquets applied. So the big one from this, the takeaway, is that if you are going to use an improvised tourniquet, then you know, you need to put a windlass of some form, whether it's you know, trauma shears. You know, Dan, when you did that blog, you used the was it the wheel brace from your car as the windlass?
Jack handle. Yep. Something rigid. There's actually a good study, and we'll punch it out in the email, looking at what works as a windlass, and there's things as diverse as chopsticks that will actually work for windlasses.
Yeah, but, you happen to have a few chopsticks in your pocket, and improvised tourniquet. So Matt O'Shea, he's asked our thoughts on the SWAT T tourniquet. I haven't got a great deal of experience with the SWAT T itself, Matt, but I've used similar Eschmark type bandages that you know, they've been used for. Yeah, Eschmark type bandages have been used for, I think, close to 100 years, and the SWAT T is very similar to an Eschmark bandage. It has its limitations. Again, that, you know, you're unraveling a rubber tape, essentially. So if your hands are covered in blood, again, it can be slippery. If it's wet, if it completely unravels, they're very difficult to apply. Very difficult to apply if it unravels out of its roll. Again, if you don't do it tight enough the first time and it's a venous tourniquet, then you can increase the amount of bleeding, which we'll talk about later, and you'd need to completely undo all those wraps around the limb and then reapply it. So unlike a windlass tourniquet where you can just tighten it, just do another half turn or another turn on the windlass, you can't do that with a rubber tourniquet. Falk is saying the SWAT T is approved by the Coalition of TCCC. That's news to me, but I'd love to see that reference. Dan, any thoughts on the SWAT T or any other rubber type tourniquets?
Oh, I might just, rather than get bogged down in that, we're coming up the half-hour mark, so might certainly. I guess my stance here is there's a whole range of appropriate devices to use as a tourniquet. There's some that the Committee on TCCC recommends, some that aren't yet recommended by the COTCCC, but may be effective. And then, as we've demonstrated in our blog, you can make an improvised tourniquet. So I don't think we need to get bogged down in specific brands. It's the concept, and that is getting a tight band and then getting a windlass. And just to add to the point here before we move on, it's interesting looking at improvised tourniquets. It's even in the setting, there's an article looking at the response to the mass casualty terrorist attacks around Paris that occurred, and they made the comment that the first responders there, despite being equipped with commercial tourniquets, were overwhelmed by the amount of casualties requiring arterial tourniquets, and they had to improvise. So even the scenario where you do have the kit, you're not caught out with nothing. You might find yourself in a situation where you need to improvise, and that's where we need to make sure you're using a windlass. And Jez has already mentioned that if you're putting say a belt on and you don't tighten it to occlude the artery, but you do tighten it tight enough to occlude the venous system, you cut off the veins, then blood can't get out of the limb, but it can still get into the limb, and that worsens prognosis. One last thing before we move on, Aaron and David, I like the comment on the ASPAT, and that'd work perfectly. You could both cause the injury and treat it with that device. So that's I like it. All righty, shall we move on?
Definitely. And as we know, our law enforcement brethren are often the first people, apart from the bystanders, they're the first people on scene a lot of the time. So they are doing a lot of these initial tourniquet applications. All right, so mistake number 3 that we see, Dan, is not dressing the wound after we apply a tourniquet. So I'll hand over to you for this one.
Yep, so number 4 we're up to here. So look, dressing the wound, and this is one where this once again needs to be taken in context. So it's the timing that's crucial as to when you dress the wound. So what we're doing when we're applying a tourniquet is we're cutting off the blood supply, to the arterial blood supply to everything distal to that tourniquet. So we use this, as everyone in the audience is aware, if someone's bleeding arterially, we want to cut that off and stop them leaking blood. Now, certainly you do want to come back and dress that wound after you've applied a tourniquet. There's a couple of reasons for that. So the first priority is to cut off that blood supply. That's what your tourniquet does. So it's in terms of when you look at, say, your primary response acronym, and Stuart's just mentioned it there, the dressing is in C of March. Spot on, mate. Thanks, you've done my job for me there. So the M is your massive hemorrhage, and that's where you put your tourniquet on. Once you start talking about dressing the wounds, that's when you're coming back to the C. Now, you dress the wounds for a variety of reasons. One is that you want to try and keep the blood in that limb. Now, that's not important to the person at the time after you've put a arterial tourniquet on, because that blood can't get back into their circulation. It's useless to them at that point. But at some point, you're going to look to revise that tourniquet. You might change it to a hemostatic dressing, take the tourniquet off. And so every drop of blood you can keep in that limb might be useful to the casualty down the track. The second thing is, apart from anything else, it will continue to ooze a venous bleed if you have an effective arterial tourniquet on. So you've got biological hazard just leaking out of your casualty. And if you want to evacuate them, it just makes it cleaner. That's not a life-saving thing. That's something that you come back to when you've got the time and when it's safe to do so. The other thing that you need to consider is if there's been a traumatic amputation and a bone has been severed, particularly the long bones, the thighs, the humerus, you will continue to leak blood through the bone marrow. Now, most of the audience are aware that the blood marrow has got an excellent blood supply, and the reason we know that, we can use intraosseous to drill into it and use it just like you would a large bore drip. So think of it in that context. The bone marrow is getting a lot of blood through it. If you've had a blast injury, for example, or a motorbike accident, and the limbs come off and the bone is severed, it's going to continue to bleed significantly through that marrow. An arterial tourniquet, when you think about what it does, it compresses the artery against the bone. It's going to do nothing to stop marrow bleeding. So that's another reason why you want to put a nice firm pressure dressing onto a stump for a traumatic amputation. And the other reasons we spoke of, but once again, coming back to Stuart's point in the comments there, it is in the C of the march that you would do that. So arterial tourniquet straight away in your massive hemorrhage, sort out your airway, check your breathing, make sure there's no tension in your pneumothoraces, any issues there. And then when you come on to C, get back and dress that stump or dress that wound when you can. And then you reassess your tourniquet when it's tactically appropriate to do so or practical to do so. And it may just be that you can loosen the tourniquet and convert it to a pressure dressing.
Excellent. I haven't really got anything to add on that one, Dan, so we might move on to mistake number 5. There was no sort of further questions on that point. So technology, here we go, 5. So something that we see is not removing all the slack from the tourniquet prior to tensioning or turning the windlass. And I think most people that have played around with tourniquets or put them on, they would see, they'd see that if you don't take out all that slack, and they even say in the teachable guidelines that you need to take out as much slack as possible. So if you can still place 3 fingers between the tourniquet and the limb, then you haven't removed enough slack. So all of these, both the soft T and the cap tourniquet, and even most other commercially available arterial tourniquets, there's only so much material. So when you turn that windlass, there's only so much material before you run out of room there to turn. So if you don't remove that slack, it's just not going to provide the required amount of pressure to compress that artery and stop the bleeding. So there've been reports of a lot of the tourniquets placed on by medics, so guys who should be trained to quite a high standard, that they had patients come into field surgical teams, and sort of between up to almost 10% of those were shown to have been ineffective due to having slack. And it's easy to put on those retrospective glasses, isn't it? A lot of the time the circumstances that they place them on could be in a very high threat, high adrenaline situation. So it's easy to look back at a case sheet or a patient healthcare record and make these critiques. But we do know that unless you take out all of that slack from the tourniquet, that it's just not going to be as effective. It can be you can require up to sort of 3 times the amount of turns to get the required pressure, unless you take that slack. Stuart brings up a very good point, is that certainly with the soft T tourniquet, one of its downsides is as it comes commercially packed, it's quite large. It's quite thick, so it's harder to put in pouches or carry in your pocket or in your medical kit. So a lot of people have been doing a flat fold packaging. A couple of ways you can see that flat fold. I think ITS, Tactical in the States, and then also the Tango Mike in UK. They do a different flat fold, but you do need to cause a little bit of slack in the windlass bar to be able to get that flat fold. So it's important that prior to applying that, you need to take out that slack from the soft T tourniquet. And maybe next time we do this this sort of webinar, Dan, we might have to do a little video that'll just explain this probably a lot better than I'm articulating it. But we know that, you know, you do need to take out all that slack. You need to make it as tight as possible when applying those. So both with the cat and the soft T, I'll grasp the windlass and then I'll pull as much of that tail of the tourniquet as I can and cinch it up as tight as possible before starting to windlass. So that's mistake 5, slack, and it is one of the most common mistakes we probably see, is not taking up, just really wanting to start turning that windlass a little bit too early. Anything more on that one, Dan?
No, I think you've pretty much covered it. Just looking at a couple of the questions there. So Aaron, looking at the tactical environment, is it still tourniquets and airways and then sort the rest pending the threat analysis? Yeah, look, certainly, I mean, they're your priorities. I encourage you to have a good look at the Committee on TCCC guidelines, and it talks you through what's appropriate at what stage in the care under fire, tactical field care, these kind of things. But and then that's their guidelines. I mean, it's a judgment call, but certainly your massive hemorrhage and your airway are your first 2 priorities. They're the things that are going to kill you first. And like you say, sort the rest pending the threat analysis. You start to get into the fine print after that. But yeah, so the TCCC guidelines are a really good guidance there. I'm sure you're aware of them. If you're not, Google it and it'll give you some answers there. Demetrius, putting tourniquets on heavy venous bleeding, is it ineffective? No, it's not ineffective. And certainly there's a lot of tourniquets that end up on heavy venous bleeds in the tactical environment. And that's the scenario where you're looking at a wound, it's hosing blood, you think, oh, maybe I should, so you do. And then they can revise that at the next level of care, or if you've got a combat medic, or when you get in an environment where you can look at it closer and then work out, now hang on a sec, this is venous, it's dark blood, it's oozing out, it's not pulsatile. I'm going to convert that to a pressure dressing, hemostatic dressing if required. And a tourniquet, an arterial tourniquet, will work in venous bleeding. The reason being that you're cutting off the blood flow into the limb. And so therefore you're cutting off the venous supply. So you're cutting off the blood supply. So eventually the venous blood will leak out, but there's no more coming into the wound to leak out. So an arterial tourniquet will stop heavy venous bleeding, but it's not an appropriate, tourniqueting a venous bleed is not technically appropriate.
Yeah, great. All right, so we're going to, I know I'm cognizant of times. Steve's already got to go due to work. But so let's move on to mistake number 6. So not securing a tourniquet appropriately, Dan.
Yeah, so look, I mean, the biggest point that I wanted to make on this, or that we wanted to make on discussing it, is probably relates to in terms of commercial tourniquets, the cat tourniquet, and in terms of improvised tourniquets, it's really tough to secure an improvised tourniquet effectively, is the truth. And there's so many variables involving what kit you've used, what you're tying it off with, the environment, that one's, we won't touch on the improvised too much. It may be that if the situation dictates, you're stuck there just holding the windlass tight until a higher level of care can arrive. I mean, that may not be tactically appropriate, but the point being, you've got to secure that thing. With the commercially available stuff, I've seen a failure with a cat. Actually, I've seen it many times in training. I've seen it once real time, where with the cat tourniquet, because now we single loop it, and the newer generations of cats don't have the opportunity to double buckle it, because it was proven not required. When you just tighten up the strap before you've tightened the windlass there, it's just hanging on its Velcro. And even after you've tightened the windlass, it's still hanging on that Velcro. And if you pull the tail of that Velcro open, if it's not secured properly, you're going to lose all the tension on your tourniquet. It's going to become ineffective and fail. Now, it might sound that that's a tough thing to have happen, and something that wouldn't happen, but in the heat of the moment, when you've tourniqueted someone, you've tied it off, you're then looking to evacuate them, be that by a civilian platform, or in the military context, maybe AME. You've got a space blanket on them. Often you can't see that wound. You move them around a few times. People are bumping by them. There's a lot going on. There's lots of Velcro on military uniforms that can catch the tail of a cat, and that cat tourniquet can get pulled. The Velcro strap, the loose end, can get pulled open. You lose all your tension. Tourniquet fails. So with the cats, it's critically important to take the time to loop that Velcro all the way around, put it through the little cup catch mechanism that holds the windlass, and then pull the retaining Velcro strap over the top of it. And that's going to significantly reduce the possibility of that tourniquet failing.
Yeah, I've also seen, you know, due to that, I haven't seen a cat in anger fail with the Velcro, but I've certainly seen it in training. You know, I've heard of guys that will get essentially their duct tape. So after they apply the tourniquet, it's more so the cat with the Velcro, they'll then duct tape around to mitigate that risk of the Velcro coming undone. Now, I think, you know, I've got two sort of views on this. One, obviously, that'll prevent it from unwrapping. But, you know, if you then need to retighten that tourniquet after a move, you know, say it becomes ineffective, you start to have rebleeding of the wound, and you've got a bunch of duct tape wrapped around the cat tourniquet, you then need to try and undo that sticky tape, probably with gloves or blood on your hands, and then need to undo that tape to retighten. So
I guess in that setting, Jez, just to jump in, mate, ideally you'd just chuck a second one above it if you've got the and the ability to do so. Yeah,
if you've got a second one, definitely. All right, anything further, Dan, to add to mistake number 6?
No, mate, let's move on.
All right, excellent. So mistake number 7 is applying tourniquets over joints or over items in pockets. Now, obviously, this probably sounds a bit like common sense. You know, you don't apply a tourniquet over anything. For our law enforcement people that are watching now or carrying tourniquets, you know, these days you've got most uniforms will have cargo pockets where they keep their notepads or any other items like phones and things like that. Obviously, certainly in Australia, a lot of law enforcement are wearing leg holsters for their firearms. So again, makes it that little bit more complex. So we know that if you place a tourniquet over a joint, just due to the bony structure, it's just not going to be effective. Same if you apply that tourniquet over something like, say, a phone or a notebook in a pocket. You're just not going to have that compression around the tissue to stop that bleed. So we definitely want to make sure that we remove everything from their pockets and not place it over the joints. So we've already talked about the high and tight versus just proximal to the wound. But, you know, we will say that, you know, the TCCC guidelines state that, you know, for that initial tourniquet application, we are going to place it over their clothing or over their uniform. And then later on, we can convert that to directly on the skin. We know that with a large amount of uniforms, say winter, where you may be wearing thick clothing, lots of jumpers or pants, that it may not be as effective, or you may require further twists to have that effectiveness of the tourniquet. I mean, we see in the photo on the slide there, so that's actually a bomb suit from a law enforcement agency, and there was talk that people that, you know, you could apply tourniquet or multiple tourniquets, or even with a soft T, join 2 of them together, and that would occlude the blood flow over top of a bomb suit. But we played around for probably over half an hour, 40 minutes, and we were still having a radial pulse on the current generation bomb suits, which I believe is the same suit that they kind of use worldwide. It's one of the most sort of common suits. So that was both for upper limb and lower limb. We couldn't get any effective tourniquet to work over a suit. With a little bit of knowledge, and most EOD operators work in pairs, if not more, then you know, with a little bit of knowledge, you can actually take off a bomb suit quite quickly. So you'd be better off, you know, your risk versus benefit, you'd be better off just removing that suit as quick as you can, and then applying a tourniquet. Dan, anything to add?
Yeah, no, good. good points there. Interestingly, there was recently an article published in the Journal of Special Operations Medicine, JSOM. If any in the audience aren't aware of that, have a look at that, JSOM.
Definitely really, get on board with that.
Yeah, get a subscription there. It covers a lot of great stuff that's relevant. If you're interested in this audience, then you'll be interested in that. Looking at the use with the US Special Forces issue CBRN suit, the Joint Service Lightweight Integrated Suit Technology, and they concluded that you can actually apply it over that. So we had a fail over our bomb suit, but you can actually apply it over that CBRN suit. Just touching really quickly on some of the questions before we move on, or comments. Phil has noted that first responder with St John Ambulance don't spend any time teaching tourniquets. That really frustrates me as a ex-military person working in the civilian setting now. It's on your protocols, so you should know how to use it. And it's that old mentality of tourniquets are bad that's unfortunately still in the system, in the civilian system. We're just not learning. So look, it's push for it as best you can, mate. It's and stress the point that it's on the Resuscitation Council guidelines to use tourniquets, albeit as a secondary hemorrhage control, but you should know how to use it. You should carry them. Chris recently had a windlass break on a cat, no longer able to tension it. You're right, mate. That's a throwaway item. That does happen. Shouldn't happen as much with the newer generation, the thicker windlasses. The soft T's have got the aircraft aluminium windlass, as seen in the picture in front of you there. They're not going to fail in that manner. Sarah, yes, that's we do prefer soft over cat for that reason. The
the seventh, as you said, Dan, the 7th generation cat. I mean, it's still a phenomenal tourniquet, and one we certainly still recommend. And the 7th gen, those windlasses are significantly beefier than the 6th generation tourniquets. I think there's a photo coming up later that'll show how effective, the change they've made in that.
Yeah, absolutely. Just really quickly, Falk. Yep, blood pressure cuff. You certainly, with BP cuff is a great way of using to occlude arterial pressure. I mean, when we're taking a blood pressure, that's exactly what we're doing with the cuff. We're pumping it up until it occludes the artery, and then we release it, and we listen for that rush of the systolic, the turbulent flow coming through the artery again. So a BP cuff works as an arterial tourniquet, yes. We always want to apply a second tourniquet above, if possible. If it's too high up and it's getting into the axilla or the groin, you need to think about converting that into a hemostatic dressing or a junctional tourniquet if you've got access to one. Use tourniquets on dogs. Generally, the assessment, we did a lot of training with dogs. We worked a lot with combat assault dogs overseas, and they got shot and injured regularly. The arteries in the limbs of dogs won't bleed to the same extent as they will in humans. And the assessment that we got from the specialist US SOCOM vet was that they're not required, and that a pressure dressing will work as opposed to a tourniquet. It's tough to get a human tourniquet around a dog limb. It just doesn't work well because they're too skinny. So look, we might move on from there just to keep the thing flowing.
Yep, no worries. Definitely some good questions coming in. And then while we move on to the next slide, Dan, I'm just going to throw up another poll there. I'd be interested. We've got 100 people watching us now. It'd be interesting to find out what their preferred tourniquet is. So I'll just throw that up there now while we move on to the next slide, which is mistake number 8, not applying the tourniquet horizontal. Dan?
Yeah, just having a quick look at that poll. So plenty of cat lovers out there. It might be the access to the cat. It's certainly one of the tried and tested ones. Soft T wide, yes, that's my personal tourniquet of choice. Love it. A little bit more expensive, but certainly I think that the money's well spent. Starting to swing in the balance, but certainly cats and softies, unsurprisingly, are dominating that poll there, and then a couple of votes for the rat and some others there. But as I said before, I try not to get too bogged down into the specifics of what's good and what's not. It's the concept, and correct application is going to be the key here.
Definitely.
So mistake number 8, not applying the tourniquet horizontally. Now, in that image there, it demonstrates that tourniquet is higher on the outside of the leg than it is on the inside of the leg. And that's something, obviously, the natural contours of the upper leg particularly are going to make you want to do that. If you're putting a tourniquet high and tight, you're going to be tempted to do that because you can get the outside of the tourniquet a lot higher. The problem with this, and I've seen this one fail on operations, unfortunately resulted in a fatality where a tourniquet was applied on an oblique angle. It was tightened. The assessment was it had occluded the artery. That patient, it was at night, it was a high threat combat environment, and certainly not making any judgment. But what ended up happening was that person was covered up. They were aeromedically evacuated. When they got to the other end, the tourniquet had loosened completely. It hadn't been noticed, and that patient had re-bled and unfortunately was unsalvageable. Now, what happens in this setting is, if you look at that picture, the distance that you have to cover when you're putting that tourniquet on at an oblique angle is larger than the distance it'll be at when it was horizontal across the limb. So what that means is that if that tourniquet gets the opportunity to work its way loose, and the assessment was that the casualty that I spoke of earlier, it was the vibrations of flight that had made it come loose, the tourniquet is going to naturally want to migrate down on the outside. If that migrates down on the outside to a part of the limb that's a bit narrower, it's no longer tight enough to be occluding the artery. So you will be able to achieve arterial occlusion with the tourniquet as it's pictured there. You can crank that thing up tight enough to do it, but try and get into the habit of putting them on horizontally, straight across the limb, and that way they'll tighten down, they'll pinch in, and they won't migrate, and you won't have the opportunity for that tourniquet to make its way down, in effect be looser and lose control of the arterial bleed.
Definitely get them on horizontal. Again, I've seen another one fail due to sort of too high up in the limb and on that angle. All right, so let's move on. So just talking about that poll quickly. So 52% for the cat, 43% soft T, 0 for mat. I know in New South Wales they use the mat tourniquet there. Rat got 1%, 0 for SWAT T, and 4% for the others. I had a few listed there. It'd be interesting to find out what the other tourniquets are. All right, so mistake number 9 is not preparing your equipment or having it readily available. So, I mean, this big one is, and Dan, we were talking about this earlier, that at some stage in deployments to Afghanistan with the Australian military, they recommended, well, it's not recommended, it's the military, they enforced or directed you to have your tourniquets, the cat tourniquet, still inside its manufacturing packaging, so still within that plastic. So that way they would increase the longevity of the device. You know, and that was, I think, post the study that came out in 2011, I think it was, Dan, there, where they tested 166 tourniquets that were exposed to the Afghan environment operationally for a 6-month period, and they tested them against 166 new or non-exposed tourniquets, and they found that of those 166, 14 of the tourniquets broke versus none that were they're essentially new. Interestingly, they also were only 61% effective. So for the ones that didn't break, only 61% of them were effective versus 91% of the unexposed tourniquets. So we do know that obviously that the longer it takes you to apply a tourniquet, the more bleeding or the more blood loss you're going to have. So anything that can decrease the amount of application time operationally is going to make a big difference. So for the law enforcement guys, having a tourniquet available on their load-bearing vest or on their duty belt. And for medics, having tourniquets on the outside of your trauma packs or your IFACs, so decrease the amount of time that it takes. So Noel's saying that New Zealand policy is to pre-fold them ready for use. And that's great. I mean, certainly for the cats, which is a very widely issued tourniquet around coalition defence, is that you want to have that pre-folded so none of the Velcro is touching each other. If you have it folded with the Velcro touching, then obviously it's going to stick to itself. So you will not be able to open it up. You won't just be able to drop it one-handed and it opens up in a loop. So having that operationally set up, same with the soft tee, having the tourniquet pre-folded, and possibly even removing those elastic bands so you can easily deploy them. Having them on the outside of your pack, not buried deep inside your trauma pack, so you are able to get them. So that's something we see. The longer it takes to get it, the more blood loss you're going to have. Again, Eric brings up a good point that his cats are in the trunk of his cruiser. This is something that we see quite often down over here, don't we? Some of the police tactical units, that they have their IFACs. Obviously, real estate is really important. They're carrying a lot of gear. The operators are carrying a lot of gear on them. They're carrying radios, they're carrying mags, they're carrying a bunch of gear. So, for them, having an IFAC take up a lot of real estate can be a big deal. So we see them place them on the rear of their body armour, and so that their oppo would be able to get it off, tear off their IFAC, and then throw it to them. But you're just not going to be able to get, if you're, if you get injured and your buddy's going to remain in that fight or sort of stop that threat, you're not going to be able to get your IFAC if it's on your back. A lot of the police having their trauma kits in the boot of their car. Eric's spot on. If you're chasing an offender and get injured, you could be 100 or more meters away from your car. How are you going to get it? So it really needs to be set up operationally and available. So we talk about the diver's triangle sometimes. So I think Will from Canada, he's got a good post on his blog with the diver's triangle. Same thing, being able to get it with both hands. We know that it's a very, very small percentage of people that apply a tourniquet to their self single-handed, but it does happen. So being able to reach that tourniquet with both hands is an important thing, and that's why they use that diver's triangle. So Sam's saying a video on the correct fold of the cat. That'll be it. No worries. I'll take note of that. And we'll definitely get something up on the blog or Facebook or something like that with a fold of the cat. All right. So anything more, Dan, on preparing your equipment sort of operationally that you want to add?
I guess this is a point that goes much further than the arterial tourniquet. I mean, this goes for all your kit. And as a generalization, you want to lay your kit out medically with regards to when you're going to need it, and think about your march protocol or whatever primary survey or response protocol you're working off, and think about laying your kit out with access to the kit in that order. And so it's your massive hemorrhage control stuff that you need close to the surface. I've seen a couple of comments there talking about having to be able to put it on yourself. Absolutely, that's worst case scenario, but think of it that way with your tourniquet. And so from a tactical perspective, we used to protocol dictated that we had a arterial tourniquet on the center of our ballistic vest, so right in the middle at the front where you could get to it with both arms, so that worst case, yeah, you're putting it on yourself, you can do that. But with all your medical kits, have your tourniquets close to the surface, not in the trunk of a car, on your body, in your pockets, in your trauma kit that's accessible. Think about other things that you might need quickly as well, things like your nasopharyngeal airways, oral airways, decompression needles, the stuff that you need in those immediate massive hemorrhage control, airway, breathing type interventions. You don't want to be digging in the bottom of your pack for that kind of stuff. Quick clot pressure dressings, that kind of stuff. You want it relatively accessible in external pouches of a kit, ideally in a pocket where you can get at it. But yeah, one of my bugbears, and a discussion I've had many times with tactical police, particularly more so than military, is having your individual first aid kit, your IFAC, strapped to the middle of your back. And it works on the assumption that the next bloke in the stack is going to be able to pull that off and chuck it at you if you get injured. Now, that's a dangerous assumption, because that next person in the stack shouldn't be stopping to help you if you're shot. He should be treading over you to get to the threat and neutralize it. So it might be a while before they come back and deal with casualties. So you're really on your own. And in that environment as well, it's going to be a little while before the paramedics are going to be let on scene. If there's an ongoing tactical threat in a civilian context, then the paramedic isn't coming in. That's the other argument, is that, oh, there'll be an ambulance on scene. Yeah, there might be. They might be 20 metres away, but that 20 metres may be, might as well be 20 kilometres if they're not allowed inside the cordon.
Yeah, so, definitely. I think most ambulance or EMS services around the world, there is a very limited amount that will go into the hot zone. We're starting to see more and more with as agencies are trained up in sort of active shooter and rescue task force. But yeah, I mean, the ambulance, most paramedics, EMTs are just not going to be able to come in. So it's going to be up to those operators or those law enforcement people to sort of apply that buddy aid. All right, so going to move on down to our 10th mistake, and we'll try to keep this. We're just blowing out a bit over an hour now, so we might just try to keep this one. We could probably do a whole webinar on this mistake alone, about intermittently releasing the tourniquet to allow for blood flow back to the tissue. But I'll hand over to you, Dan, to talk a little bit more on this.
Yeah, certainly. This one is one that pops up, and the theory behind this, first of all, it's an absolute no-no. You just do not do this. The theory behind it is that what you can be doing is periodically, if you've got a tourniquet on for a long period of time, you're cutting off all the blood supply to the tissues, you're denying them oxygen, you're stopping any of the waste products that are building up in that limb from coming back into circulation, and they can build up to toxic levels. The concept behind loosening your tourniquet is that you can just allow a bit of blood flow in, allow those tissues to get some oxygen, get some waste products out of that limb. It'll rebleed a little bit, but then you do it back up again, and the tissues had a chance. It's like taking a breath, like being underwater, coming up, taking a breath, and then going back down underwater. The reason it's a no-no is a variety of reasons. If you put the thing on, you put it on for a reason. They're going to bleed out from massive hemorrhage, so you put on an arterial tourniquet. It's a life-saving device. The second reason is, if you start loosening off tourniquets, once you've tightened them properly, particularly the cat, due to its internal ribbon being a little bit more flimsy than the softies, you'll stretch that ribbon, and then when you loosen it off and go to reapply it, you're not going to be able to generate the same amount of tension a second time. So even if you did do this successfully and then reapplied it, there's no guarantee that the tourniquet is going to work a second time. Other factors to think about here, arterial tourniquets hurt. They hurt like buggery, and the casualty, if they're conscious, is going to be in a lot of pain. They're on occasion going to, if they don't understand, they're going to be begging you to take that thing off, or to release it a little bit, to give them some blood flow, relieve the pain, basically. So you want to resist that temptation that the casualty might be screaming at you. You manage the pain within your protocols and within what's appropriate for the casualty's overall state. You give them pain relief if it's available to you. If it's not, you just stick to your guns, leave that tourniquet on, reassure the casualty that it's required, it's life-saving, and get them to a surgical facility as soon as you can. They won't thank you at the time, but it's life-saving. They're going to certainly, it's a better option than trying to be kind, loosening it off to ease the pain, and have it fail and they bleed out and have a bad outcome. Certainly, you don't want to leave it on long term. I mean, you want to get that thing off as soon as you can. Now, your options for getting it off are to, if you put it on in the care under fire phase or a tactical type environment, then the first opportunity you get when it's safe to do so, you want to reassess it. So have a good look at the wound, cut the clothing off, work out if the wound is actually arterial or venous if you can, if you're appropriately trained to do so. Convert your tourniquet to a pressure dressing or a hemostatic dressing at that point if you can. That's the first available time when you might do it. Now, the caveats to that are, you never take an arterial tourniquet off if the casualty is in shock. If they're already shocked, then don't take that thing off. That stays on. Get them to definitive care. If it's not possible for you to monitor the bleed, then you don't convert it to a hemostatic dressing. So don't change it to hemostatic dressing, take the tourniquet off, and then have to walk off. Or if you can't, keep an eye on that and be sure that you can be there if it rebleeds and put another tourniquet on, then don't remove it. And also, if the limb's been amputated, if the limb is missing, then the tourniquet stays on. You don't try and convert that one to a pressure dressing. You just leave it on, get them to surgery. Certainly, the TCCC committee has agreed on 2 hours being the upper limit of when you want to review your tourniquet. So 2 hours is a safe window where you're not going to have done permanent damage, and you're very safe to leave it on for that period of time. So if you're within 2 hours of getting to a destination medical facility, so in the civilian environments, paramedics, if you put a tourniquet on, and you're within 2 hours of a facility, don't even think about taking it off. Get them to the facility. And certainly, if we had a comment earlier about regional medics and remote working in great distances from care, if that thing's been on for more than 6 hours, don't remove it. They need to, until you can get them to a facility that's got appropriate cardiac monitoring equipment and has got appropriate blood monitoring equipment. So the reason for that being is at the 6 hour mark, after that, there's going to be so many toxic metabolites, particularly potassium, built up in that limb, that if you release that and all of a sudden allow them back into the body's circulation and that hits the heart, it's likely to put them into cardiac arrest. And so you want to be able to monitor them appropriately and deal with that as appropriate. So that's the guidance, but certainly intermittently releasing the tourniquet to allow blood flow is an absolute no-no.
Yeah, I could sort of picture it now. It was over 10 years ago. I had a coalition medic release a tourniquet on a pediatric patient, trauma patient from an IED. And as soon as he released that tourniquet, the limbs started to rebleed, and the ped might have probably just had enough circulating blood volume to keep them quite stable. But as soon as they rebled, they just crashed and couldn't be recovered, and subsequently died. And that was just a decision he made on his own, due to the tourniquet being on for around about the 3 hour mark by the time they reached us. So it can be a fatal mistake. So it's just something to be aware of. All right, Dan. So where can people? That's all 10.
Can I just, sorry, Jez, looking at Demetrios, in the darkness situations, how do we know if the tourniquet is in place and has stopped the bleeding? Sarah, spot on. Check the distal pulse. Make sure the blood flow is being stopped. That's exactly right. So if you can still feel a distal pulse after you've put a tourniquet on, it's not tight enough. Yeah, it hasn't done its job. You need it to be cutting off the artery, and you shouldn't be feeling any pulse distal to that. And that's exactly how you can check effectiveness of your tourniquet. It should have stopped the arterial bleeding, so the wound shouldn't be bleeding any longer, but also there shouldn't be a distal pulse. Thanks for that, Sarah. Sorry, Jez.
No, that's all right. So that we're just a bit over probably an hour and a quarter now. So that's all 10 of our mistakes. And I think, Dan, we could talk all day on tourniquets. But where can people find out more, Dan?
Yeah, so look, we've TacMed's released the ebook that you see in front of you. It's also available in hard copy. So arterial tourniquets, it's aimed for any first responder. I mean, we've titled it for police officers, law enforcement, other first responders. It is a blow-by-blow description of it. Starts with the physiology of the blood supply to limbs. It talks about what we're aiming to achieve with arterial tourniquets. It goes into great depth on everything that we've discussed today. We've kind of touched on the wave tops here, but it goes into a lot more detail on all of that, and then talks about training and what have you. It's very heavily referenced. So a lot of the references that we've spoken of today are in this book. Look, thanks for the feedback. A couple of people talking about they bought the book. Thanks for that. What we're aiming to achieve with this is just to raise awareness, get people thinking about these tourniquets, get people who are aware of it just to think of the finer detail of it, which is the other objective of, well, the main objective of this webinar. And just based on what we've seen over the years with cumulatively in the TacMed community, dozens of years of combat experience using these things in actually combat environments for real-time arterial bleeds, and trying to get that information across, particularly in this day and age of increased transnational terrorist threat. We're seeing these events occur, unfortunately, on the streets of our first world cities. It's coming to Australia. The intelligence organisations are convinced, and we've got the opportunity here and internationally to get ahead of the curve with our civilian response by employing some of these military techniques. So if you've enjoyed this webinar, then I do encourage you to get on, have a look on the next slide, Jez, if you want to click it over. So if you go to that link there, so just tacmedaustralia.com.au, so our website, and then /ebook, there's a page there which has got a bit of a blurb. It's got a free chapter from the ebook, so you can get a bit of a feel as to what it's all about. But it's just a significant elaboration on everything we've spoken about this morning.
Definitely.
So, and as is noted there, we've got it in hard copy. So we've got the hard copy books, and if you want one of those, just get onto us through the TacMed website, and that's just a bit of a look at it, and we'll get one of those out of you in the post.
Yeah, excellent. So guys, that brings an end to our webinar. I don't know about you, Dan, but I certainly enjoyed the presentation. Hopefully, as our first, I think technically it went all right. I don't think we had too many technical failures. A couple of sound in the start, but you know, I hope you learned something from this webinar. Hopefully, we're going to bring you a lot more webinars in the future. Drop us an email at info@tacmedaustralia.com.au if you've got any other ideas on webinars or any further questions or feedback from today. Would really appreciate it. And you know, it doesn't matter who you are, whether you're a special operations medic, a police officer, a paramedic, EMT, or you're just driving in your car, full driving, camping, on the way to work. It doesn't matter what tourniquet you carry. It doesn't matter who you are. We really encourage that people carry a tourniquet and not be afraid to use them. So from me, thank you very much. Dan, you want to sign off?
Yeah, absolutely. Look, just wanted to say thanks to everyone who's attended this webinar. Really appreciate your support, but more so the fact that you're attending this webinar tells me that you're the sort of person who might be in a position to apply a tourniquet. And so you're out there, you're doing the job, you might be in a high threat environment. And so basically just wanted to say, thanks for turning up this morning. TacMed really appreciates your support, but more so, thank you for doing what you do. I mean, you guys are on the front line there, saving lives, and that's a big deal. It is a big deal. It's a big burden to carry, but thank you guys. Cheers.
Thank you. All right, guys. So we're gonna sign off. We're gonna sign off there. We thank you again for watching. There is going to be a replay of this link. So if some of you had to leave early and didn't quite watch all of it, or if some of you want to watch it again, we're going to place up a link at some stage when I work out how to get it to work. It'll probably be a YouTube thing, I'm led to believe. But yeah, we'd appreciate it if you share any replay links to anybody you think would be interested. So thanks again, and have a great week. Catch ya.